consultant at Cloud9 Hospital, Parpadganj, as well as Apollo Cradle Hospital, Indrapuram. She is a proud recipient of DGF Teaching Excellence Award in 2017. Welcome, Dr. Aruna Saxena. To chair the session, we have Madam Sharda Jain. She needs no introduction. Ma'am is Director, Life Care Center, and Dr. Jyoti. Next is Dr. Jyoti Agarwal. She is Senior Consultant and Director at Life Care Center and Life Care IVF. She is Advisor of DGF East. She is DGF Certified Trainer for Infertility and IVF, Ultrasound, Colposcopy, and Thermal Ablation. She has various awards to her credit, and she has been gold medalist throughout her education time. Next expert we have is Dr. Seema Sehgal. Dr. Seema Sehgal is an expert in laparoscopy and hysteroscopy. She is Director and Senior Consultant at It's My Baby IVF Center. She is Medical Superintendent and HOD of Gynae Obs at MKW Hospital, Rajouri Garden. She also has various awards to her credit. Welcome, Dr. Seema Sehgal, ma'am. Next expert we have is Dr. Jyoti Malik. She is a Senior Consultant OBGYN and ART Specialist. She is Secretary DGF Outer Delhi. She is Director JJ Institute of Medical Sciences at Bahadurgarh, Haryana. She is Director and Chief Consultant of Roots IVF Infertility Institute. Welcome, Dr. Jyoti Malik. So I request Dr. Aruna Saxena to start her deliberation.
Thank you so much, Dr. Renu, for your kind words. Can you see my screen?
Yes. Yes.
All right. I would like to thank DGF for inviting me for this talk, and it is my proud privilege to speak on this very interesting topic in front of my teachers, Brigadier R.K. Sharma and Ma'am Sharda Jain. I did my very first embryology training under Brigadier Sharma in Pune. So with these words, I'm going to talk about this very interesting topic. Sir has just discussed that globally over 180 million people are struggling with infertility, and 50% of them are because of male factors. And in 50% of these cases, the cause is still unidentified. But if we make sperm DNA fragmentation as a routine test, probably it can play an independent and significant role in its etiology in 1/3 of the cases. Now, sir has beautifully discussed about the sperm DNA damage, how it is caused. So I'm not going to discuss in detail, but certain factors like aging, smoking, pustules in the sperm, infection in the sperm, neoplasia, chemotherapy, radiotherapy. These are the factors which can cause DNA damage through these processes like apoptosis, oxidative stress, and impaired chromatin packaging. So now, how to check whether the sperm DNA is fragmented or not? There are direct test and indirect test. The most commonly talked about test is tunnel test. It has got an impressive name, but don't ask me technical details. I won't know. But the tunnel test and the alkaline comet test, these are direct tests to measure the DNA damage, and they have shown a clear correlation with assisted reproduction results. And there's, at the same time, there are certain indirect tests which test the sperm chromatin integrity, and these are the tests which are usually used by most of the lab when we order a sperm DNA fragmentation test for our patients. So once you know that your patient has high DFI, the first thing is to treat the oxidative stress, which again sir has discussed in detail. I don't want to go in detail of all this. Now, my concern is that you have given antioxidant, you have done your part. Now what? The biggest dilemma of infertility expert is that now what to do? Can we do IUI for these patients? Of course, yes. If your patient is a young patient with a short duration of infertility, you can treat the patient for high DFI and try for IUI. But if repeated cycles of IUI do not give you a result, then what? Can you go for IVF or ICSI? Here, the answer is only ICSI. Why? Because in IVF, we just leave the oocytes and sperms side by side in a petri dish, and the sperms have to penetrate the oocytes, and obviously the sperm with the DNA damage, with a poor quality, will not be able to penetrate the egg. So the answer in case of high DFI is only ICSI. I would like to tell everyone present here some basic tips when you're preparing a semen for a patient with a high DFI, high DNA fragmentation index. The abstinence period should be short. You can ask your patient to have just 1 day abstinence, or maybe have intercourse in the previous night and come for the IUI next day. And when we are doing IVF for these patients, many times we tell them, we ask the husband in advance that you have to produce 2 samples 1 hour apart. And the next sample will be cleaner sample with less DFI. Of course, the counts will be less, but the quality will be much higher. The patient should be instructed to deliver a specimen just before performing ART, and the semen sample should be processed as soon as possible. The incubation time after processing should not exceed 4 hours in case of ICSI, and if it is IUI, it should be immediate. If you are using cryopreserved specimens, the thawing should be done just before performing ART. And if nothing works, then use of testicular sperm should be considered. Why testicular sperm? Because the sperm DNA damage is reported to be higher in ejaculated sperms, as discussed in detail, because the spermatozoa pass through epididymis, and when those who are having infrequent intercourse, the spermatozoa they're accumulated in epididymis for longer time with a lot of dead sperms, and a lot of ROS produced by these sperms, immature sperms, leukocytes. That leads to more DNA damage in cases in ejaculated sperm as compared to testicular sperm. The sperm DNA fragmentation level measured by tunnel assay was found to be lower in testicular sperm, and also when the testicular sperm were used in these patients, it led to higher pregnancy rate of 44% as compared to 23% in one of the studies. But mind you, the birth rate was significantly lower in the testicular group. Now, certain frequently asked questions about the sperm DNA fragmentation. Number 1, should DFI be done if semen analysis is normal? The answer is yes. Why? Because the standard for normal values in semen analysis, they do not reflect average value, but they are instead determined using the bottom 5% as a cutoff. What does that mean? It means that this is a minimum standard for pregnancy. This is not the average for that population. So, if we are only doing normal semen analysis, we are missing a very important component called quality of sperm. So DFI actually measures the sperm as the DNA package carrier, and it actually talks about the quality of the sperm. To understand how a patient with a normal semen parameter can still have male factor infertility, I'm just going to discuss a short case. This couple, 37 years old female and 39 years old male, came to me around 3 years back. She was a known PCO. They were married 12 years back. She had 4 failed IUI. However, she conceived spontaneously twice, but landed up with miscarriage at 5 to 6 weeks. She also had 2 failed cycle of IUI at IVF at Bonehall Clinic, and both the attempts, blastocyst transfer was done. It was a frozen embryo cycle, and still she failed. She was carrying a very impressive embryology record from the clinic, and it showed that during the first IVF cycle, 26 oocytes were retrieved, out of which only 16 were mature. That was a time when the people were doing ICSI for all. So probably that is why that clinic performed, denuded all the oocytes, and only 16 were mature. ICSI was done for all. Luckily, all the oocytes fertilized and all the oocytes cleaved as well. They froze 3 good quality embryos on day 3, but when rest of 13 embryos were allowed to grow further, she formed only 2 blastocysts out of 13 embryos. The rest of the embryos were arrested at 4 to 6 cells. Now, what does this information tell us? This means when the embryo quality starts degrading day 3 onwards, there's a male factor involved. Because the paternal genome, they start operating 3rd day onward. So this patient was prepared for a second cycle. Her AMH was 12, AFC was 30, BMI was 28. Semen analysis was fine, except that little viscosity in the sample. The counts were reasonably good, 50% motile, rapidly progressive, a lot sperms were rapidly progressive. So I didn't understand why this couple still have male factor infertility, but still, because I could see in the previous record that day 3 onwards embryo quality was not good. I counseled the couple, like, say, look, you have got a lot of eggs, and can we try few eggs with the donor semen? Since it was the 3rd cycle, practically 3rd cycle for them, and as you know, the IVF cycles are emotionally and financially draining. The couple agreed that, okay, let us try a few eggs with the donor semen. Because otherwise, if you do not do, this time again, I use all the self semen, if it fails, then what is the next option? You change either of the gamete. So I counseled them and they agreed for use of few oocytes with the donor semen. This time again, we got 26 oocytes, but we did IVF for 10 of the oocytes and 16 were denuded for the ICSI. Because, these days the concept is that you should not do ICSI unnecessarily if the male factor is good. So we are doing sibling ICSI for normal male factor. So the 10 oocytes were taken for IVF, 5 with self semen, 5 with donor semen, 16 oocytes were denuded, 11 were mature, ICSI was done. Next day when the fertilization was checked, in IVF the fertilization was 100%, but in ICSI fertilization was not so great. But at the end of day 3, we had 10 very good quality embryos from the self semen, which were frozen, and 3 good quality embryos from the donor semen as well. Now it was time to transfer the embryos. In the first cycle, because she had already 2 previous failures, I thought 6 embryos on day 3 and allowed them to grow. Unfortunately, she did not form any blast on day 5. All the embryos were arrested at compaction or morula stage. So the ET was cancelled. And the couple was so distraught, they did not come back to me for 1 year. In the meantime, she had a spontaneous conception and a missed abortion again. And this time microarray was done for POC. It was normal. And before that, they had undergone karyotype for both the partners. And they had undergone all the possible tests you can think about, RPL and recurrent implantation failure. Everything was normal. Now, they came back to me 9 months back. They said, doctor, now we are aging. The woman is approaching 40. She said, we just want to have a baby. We don't care whether it's donor or cell. We just want to have a baby. So I said, okay, I have few embryos with the donor semen. Let us try this time. We did the transfer, and fortunately, she conceived this time. She conceived of twins. One of the twins vanished at 6 weeks. Second continued till term, and today only she delivered a healthy male baby. So these are the cases which give you indirect evidence of male factor infertility. The excellent count, excellent everything, but still there's a male factor involved. So I was wondering, should I have offered this couple a DFI test, which I did not offer that time 4 years back. But when I was preparing for this, I was wondering if I would have offered them DFI. Probably I was able to give them a genetic child of their own. If this male was positive for high DFI, I would have could have taken testicular sperm. Probably I would have been able to give them the genetic child. But if you see the embryology record, there was 100% fertilization in the IVF. So this was probably not a case of high DFI. Otherwise, there would not be 100% fertilization in IVF. So maybe there's some factor which we still do not know what went wrong in this couple. But ultimately, if the end is good, everything is good. So now the second scenario is that what to do if the semen parameters are very bad? If it is a case of severe roots, are we justified in doing DFI in these cases? Because anyways, we are going to do ICSI for these patients. What is the point in doing DFI? Yes, even in these cases, DFI is important. Why? Because when we are doing IVF, the selection of sperm is natural. But when we are doing ICSI, we are the one the embryologist is the one who is selecting the sperm. So we may choose a morphologically normal, but genetically abnormal sperm, which has a lot of DNA fragmentation, high DNA fragmentation. So it is important, even if you're taking your patient for ICSI, check for DFI and take the patient for ICSI once the DFI is improved if it was high. Otherwise, what will happen? We can land up with the lower pregnancy success rate, increased rate of miscarriage, chromosomal abnormalities, and other genetic or birth defect in the offspring. Now, the third scenario, how is DFI assessment useful in planning IUI cycle? Is it useful? Sir has already described, but I just wanted to repeat it that the possibility of pregnancy using IUI was close to 0 when the DFI was higher than 30%. So measuring DFI is beneficial, predicting IUI result ahead of time, and especially if your repeated IUI cycles are failing, it is important that you do DFI because then it is very easy for you to counsel the couple. And you also know that this patient is not for IVF, rather straight away you should go for ICSI. A word about RPL, although this is not the topic for today, but I just want to talk about a short case. A young couple came to me with 2 miscarriages. Her ovarian reserve is fine. She had a missed abortion at 8 weeks, and next pregnancy landed up in the chemical pregnancy. All the investigations were normal except hypothyroidism, husband semen analysis, other biochemical markers, everything was normal. I did the semen analysis, it was fine. It was just the little viscosity in the sample, everything else was fine. I didn't know what to offer them. So I randomly asked them to do a DFI, and to my surprise, it was 55%. I put the man on antioxidant for 3 months. Fortunately, they had a spontaneous conception and they all delivered a healthy baby already. So the take-home message, so the algorithm for the management of high DFI would be, once you have identified that this man is having high DFI, look for the presence of correctable factors, as I already discussed. You can do lifestyle changes, you treat the genital infection, treat the varicocele, whatever is present there. And after the treatment, you can ask the couple to have shorter abstinence and try naturally if other factors allow you to have an IUI or natural cycle. But if this patient is for IVF or ICSI, you repeat a DFI and it's still persistently high, go for ICSI rather than IVF. And if there are no correctable conditions which are associated with high DFI, directly go for ICSI. And if nothing works, go for testicular stem. So the take-home message from this presentation would be, DFI is an important investigation for male partner. We should not stop at semen analysis alone. 50% males have high DFI with otherwise normal semen analysis, so we should not forget this point. And see, a lot of us are doing IUI day in and day out. And if we do the simple investigation, it will probably help us in predicting the result of IUI cycle. Also, it can help us in counseling couple that when to switch over to ICSI. In case of persistently high DFI, testicular sperm is the treatment of choice. Thank you very much. Thank you for your patient hearing, and thank you very much.
Thank you, Dr. Aruna. And now I request Dr. Sharda Jain ma'am to give her expert comments.
Congratulations, Dr. Aruna. Excellent presentation. I just simply love DNA fragmentation index. And I feel, anybody who is married for 1 year and the semen parameters are normal, if you get a DFI done in such patients, you'll find good, and I'm talking of good, 60% patients will have high DFI. And not 30%, they will have 50%, 60%, 70%. I used to get very upset, when in IVF, things, they used to fail, and I very sincerely have started, sir, can we have this particular slide off so we can have things? What I find is that if the DFI is high, even if you give them a lifestyle changes, flood them with antioxidants, and I find, the people who have given at least minimum 3 to 4 months, you find the results are improving. If you just rush through and you say, "Hum to ICSI kar hi lenge, to ICSI is the only treatment," then probably it will have a good results. No, in ICSI also, one thing, IUI will not work. The conventional IVF will not work. The only thing which is going to give some results is ICSI. And ICSI also, they have got less results, success results, than in comparison to ICSI done for anything else. So I think I am very fond of this particular test, and I find each one of you, anybody who is married for 1 year, had not been using a contraceptive, semen analysis alone is not enough. 2021 WHO guidelines which have come have very mandatory have said that DNA fragmentation should be part and parcel of evaluation of the male partner. And I think, this is one particular test. And previously, people never used to say about the male infertility. We started speaking about 20 years back that the male infertility is to the tune of 50%. And you can take it from me, 10 years from now, everybody will be talking about DFI, and DFI, because I think their contribution is much, much more. And unless they change their lifestyles, and unless they take the flood the antioxidants, things are not going to improve. Somebody asked about the questions, how long the antioxidants have to be taken. They're expensive. But आपको 3 महीने में तो असर आएगा, और 3 महीने के असर के बाद आपने छोड़ दिया तो असर फिर नीचे चला जाएगा. So I think they have to be continued whether they like it or they do not like it. So I would like to have other people's comments on the same.
I request Dr. Jyoti Agarwal to give her expert comments.
Thank you, Dr. Renu. First of all, my sincere thanks to Dr. Aruna for giving us such a nice talk. And especially I liked your case where you have beautifully explained in a very simple way what is male infertility. So as far as male infertility is concerned, what I gather from the talk is not only semen analysis and genetic or maybe infective etiology, it is much beyond that. And DNA fragmentation index is definitely one of it. DNA fragmentation index, we can categorize as mild, moderate, severe. It indirectly tells us about the health of the sperm, how healthy the sperm may be. Irrespective of the semen parameters, even if it's normal, DFI is very important. And here I would like to stress, besides the intrinsic factors and the extrinsic factors in causing increased DFI, we have all taken care of antioxidants and everything. We need to see for the varicocele also. Much has been talked in previous lectures about the varicocele. If it is a clinically evident varicocele, because in good 40 to 50% of cases where varicocele operation is needed, it can also increase the DNA fragmentation, and it is a correctable form of male infertility. So we should not forget this. And another two more things which I would like to add is patients with insulin-dependent diabetes mellitus needs to have a very good control, and very obese patients with a very high BMI also needs to have a good control before they go for infertility. And very beautifully, Dr. Aruna has explained, if they conceive spontaneously, it's a blessing. But if they don't, either they go for IUI or for IVF, ICSI. Wasting time on IVF is not to be done. Time is not to be wasted for IVF. Straight away, ICSI should be informed. Thank you, Dr. Aruna, telling us about. What I would just like to know, at our center, we are doing it for all the patients of infertility. So do you recommend that it should be done for all the patients? Because even if the semen is normal, the DFI may be very high, yes, and the results may not be good, and it helps in counseling the patient. Patient को भी पता चलता है कि हाँ मेरा इंडेक्स इतना ज़्यादा है तो results अच्छे नहीं है, infertility भी हो सकती है. तो क्या आप सबके लिए recommend करोगे?
See, everyone coming for IVF and even those who are coming for IUI, this first cycle, I may not go straight away for the test, but yes, if repeated failures of IUI cycle, yes, I would like to go for it.
I think it is must. Time has come. 10 साल के बाद आप सुनेंगे कि ये चीज है. DFI only tells you what is the the quality of the sperm.
Yes.
Semen count may be normal, but DFI assessment is very, very vital. Dr. Seema, you want to say something?
Very nice lecture, Dr. Aruna. Really, I am also very fond of DFI, and when you don't have any other thing to say and explain about failures of IVF, failures of repeated implantation failures, repeated abortions are there. So DFI gives you the answer. And many times I have seen one patient with normal conception. She had 3 missed abortions. So she came to me first time and I just wrote this DFI, and her DFI was 75%, like her husband's. And to my surprise, we gave her this man this antioxidant for 3 months, and after that we repeated it. It comes around 35%, and then she conceived, and her pregnancy carried on nicely. And what happened this time? She came to me after conception, second pregnancy. She has delivered nicely in first pregnancy, but after 2 years of first pregnancy, she again conceived, and at that time DFI was not done, and she again aborted. And she reminded me of this test. She said कि test तो कराया था, अब की बार हमने ऐसे ही conceive कर लिया. So that way I feel DFI plays a big role also.
Yeah, it is especially important in early abortions.
Yes, very early abortions. Yes,
Yes.
she is a typical case, because DFI and afterward DFI, both reports were different. So this is a wonderful test, I feel.
This is one particular test I'm talking about, the general gynecologists who are doing an IUI. Please include this into the investigations. The test is a bit expensive, it costs something like 6,000 to 7,000 rupees, but I think it's worthwhile because when it is positive, no IUI is going to work, no conventional IVF is going to work. Only sometime, the results are going to be only from their ICSI. But if you work hard on them, on the changing the lifestyle and giving them, flood them in antioxidant, things are going to work. And this Acumen test does a training course for seminology as well as to do a DFI. I will give you the number, contact them, and they will be very happy to organize a training program for you on a seminology as well as a DFI. I'm sure each one of you who gets an opportunity should get it done. And it's a wonderful test. You can take it from me. I may not be there 10 years from now, but you will definitely know that the lady definitely said about the DFI, because this is going to be the test for tomorrow. So thank you very much. I think both Dr. Sharma, I wish you to have, make a comment as far as the DFI is concerned. Sir, if you're there. Dr. Sharma? I think he had an exhaustive lecture. We will wind it up today.
And Dr. Jyoti Malik's remarks.
Well, Dr. Jyoti Malik, you want to say something? Dr. Jyoti Malik? Anybody wants to make any comment? Anybody wants to comment as far as the DFI is concerned? Dr. Jyoti Malik? Anyway, we will wind up. Thank you very much, Dr. Sharma, as well as Dr. Aruna Saxena. You opened a Pandora box, and I think the time will tell that you spoke every line, which was absolutely correct.
Thank you, ma'am. Thank you so much.
Thank you so much. Thank you very much.